Video consultations were originally seen as a panacea of general practice, but it hasn't kind of worked out that way. So, are they useful for us to use in general practice currently? As many more clinicians seem to focus on telephone and face to face, what is the place of video consultations in general practice? In this episode, I'm joined by Rebecca Payne as we talk about that, situations where you may find it useful, and some of the recent evidence that may support or not the use of video consultations in general practice as we tech enhance your primary care and learning. Hello, EGP learners, and welcome to this episode. I'm joined by Rebecca Payne talking about the use of video consultations in general practice. I guess it's a really topical time to talk about it. We have obviously seen a lot of shifts happen within general practice as we move back towards telephone and face-to-face, the predominant method of care. But actually, video does have its place in general practice. And we're going to talk about that, especially with obviously the new SCA exam focusing on video assessment and how much impact that has. So I think it's a really topical thing to talk about. I'm really happy to have Rebecca here to talk about it. How are you doing there, Rebecca?
Hi, lovely to join you.
Thank you. Now, I understand you've had a recent trip that's been a little bit of fun and a little bit of chaos as well with it. Tell us about that, first of all, so the EGP learners get to know you.
Yeah, so I have the coolest job in the world. I work 3 weeks out of 4 for Oxford University researching technology in healthcare, and I work 1 week in 4 as a rural GP. So I'm just back from the Falkland Islands, where I actually managed to wangle a month off to go see penguins and be one of the GPs there. So it was absolutely amazing. I had a day of flying doctor, which I think is a highlight of my career, zooming around on a little Britain Norman Islander to remote and isolated settlements to see patients, all the while with a screaming cat in the back, because the plane doesn't just take doctors, it takes livestock too. So yes, I love my job. I'm probably the most enthusiastic GP you'll ever meet, but I really like video consulting too, and really pleased to be here talking about it and where it can actually be useful.
Cool. So I guess working quite rurally, video consultation probably has more of a use than I guess some of the inner city GPs and community-based ones may have experienced. What's been your experience with using video consultations?
So it always makes me think of my dad's advice about DIY. And my dad gets very upset when his daughters start trying to hammer things in with a screwdriver or using completely the wrong tool. And he likes to say there is a tool for every job. And I think that's a really helpful way to think about video consulting, because a lot of the problems come if you try to use video consulting for something that a photograph would do or something that a face-to-face is needed for. But actually thinking through what is the problem I'm trying to solve here and what is the most appropriate modality for that is super helpful. So I find video consulting brilliant for that middle of the night conversation as an out of hours GP, where I've got a child maybe 45 minutes away and I need to be sure that it's reasonable to ask the parents to pack them in the car and head out, often in a Scottish Island storm, to see me. And having that video there is really helpful to see, is this kid sick? Are they not sick? And help provide information that helps me make a sensible decision and a justifiable decision about the modality of contact. It's also really good for those patients where rapport is difficult, because as we can talk and see each other, we've just got so much more connection than we would have if we were just disembodied voices on the phone. So it's really helpful for rapport, and a lot of out of hours services find it's useful for reducing complaints. I think it's really helpful as well if you've got somebody who can facilitate an examination. So a care home, perhaps, where a nurse can give you a set of obs and show you various bits on the patient, maybe pop a hand on their tummy, or a paramedic where they can listen to the chest for you and report back the findings. So there are a few of the things I find it helpful for. But again, it's what is the problem you're trying to solve, and is it helpful? Because if you try and use it on the patient who lives around the corner and just wants to pop in, all that faff probably isn't helpful. Or if the patient is just wedded to the idea of a face-to-face, or if the patient struggles to get the technology working, then, you know, for that one, a telephone call would be better. And I think skin is a really challenging one, because some places you get great connections and you can see skin lesions. Other places you're just much better with a photo. So know what the problem is you're trying to solve, and then see if video consulting is the tool that you want to use to do it.
Absolutely. I mean, I definitely agree with what you mentioned about the skin side of things. It, generally speaking, a photo is far superior when it comes to video consultation. Often that's down to the resolution more than anything else. That most of the video consultation platforms won't allow you the same resolution that a still photo would do. I guess can be useful for depth. I mean, that's one of the challenges sometimes with photo. But again, the reliability doesn't work as well. But also agree absolutely with those comments you made about the facilitated consultations. So I guess, when you've got somebody else with you, whether that's a formal person like a carer or support worker or something like that, or informal, which obviously be things like parents, relatives, friends, that kind of stuff to help out and things, versus I guess that remote aspect of the consultation, so either clinician being remote, like you said, out of hours in a call center, for example, or working remotely, or obviously rural, where it can be considerably bigger than what I probably see in inner city Nottingham and stuff. So I guess, can you give us an example where that's worked out really well? You mentioned obviously out of hours and stuff. Anything that you found where the video has just kind of been, if we hadn't had that, it could have gone so much more differently?
Yes, I've got a few examples from my research into it, doing focus groups with GPs that use it regularly.
Mm-hmm.
And the kids is a really classic one. So there was one example of a child with appendicitis, and the doctor was able to use the mother, she described it as an avatar. I love that idea. And mum sort of pressed in the right iliac fossa. The child had a real tenderness there, really good going story for appendicitis as well. And due to the sort of she had based on that facilitated video consultation, she was able to get the child straight to the surgeons rather than bringing them into out of hours for a face-to-face assessment and then on. So it really improved the patient journey and meant that the child had their surgery in a timely fashion, which was just brilliant. I have another example from Wales where a GP had a patient with a possible arterial problem with the leg, and was able to bring into the call, so sort of three-way call, the specialist, the patient and the GP, and actually get the patient again to the right place for their symptoms, rather than them waiting hours and hours for a face-to-face out of hours appointment and then going through. So situations like that really save time. There are a few examples where people spoke to families on the phone. The kid didn't look that sick and said, "Oh, just have a look on the video." The child was really working away, rapid respiratory rate. They could see tracheal tug and intercostal recession. And again, just allowed that child to get to the right healthcare first time.
It was interesting you talked about the bringing the specialist into that. I have long felt that that's one of the opportunities I think I'm missing with video consultations, to have particularly outpatient appointments with patients. And I know some trusts are looking towards that, but actually that joint consultation, the acute, do I actually need to send this patient into you? Let's have a look. Let's do the video together kind of thing, either with them in the room with you or, like you say, completely three-way. That has real potential value, I think, particularly as we move towards an integrated care system where we're trying to streamline the pathways that patients have. We're all working within the same goals and all that kind of stuff. That may be one of the areas of the future to look at. And so I guess if there are any ICS people out there watching this, maybe that's something to think about and stuff.
And it's not the future. In Scotland now, this is happening. So I was working on the island of Barra back last year, and respiratory clinics, I think something like 2/3 of them happen remotely, with a patient going into the hospital, little community hospital on an island with 1,200 people, and having an HCA support it. And then the consultant at the other end in Inverness or wherever he was. And it's massively cut down the amount of travel, both for patients, but also for doctors too, in terms of bringing a specialist onto the island. So the Near Me team in Scotland have got lots of resources on their website to help ICSs and others as they develop models like this, because this is normal in Scotland.
Sure. And absolutely you can see the value of that, like you said, in the more remote rural kind of practice and stuff. I think I'm also thinking about that inner city kind of where the rurality is less of an issue. It's that concept of, does this person actually potentially need an admission? Because often you get some of that, I'm not sure, do I need to, do I not need to? And actually having that joint consultation mode may actually help to weed out the ones that definitely need to go, maybe need to go, and actually, to be honest, know that, what you've shown me, like you said, doesn't really think we need to do this, this, and this, and let's think of a different plan that's more sensible. But also may help with that primary secondary care divide about the whole, they're just dumping it on me. It just may help, like you say, with the rapport side of it as well.
Yeah, and if they've been part of that decision-making process, it's always a lot easier, isn't it? But just going back to the urban areas, the other thing I think it's super helpful for is getting a glimpse inside people's homes. So I
Mm-hmm.
remember, I feel a million years old saying this, but when I first started in general practice, we used to do home visits to all our patients who just had a baby. And stepping foot in that home, looking around, seeing the level of chaos and what support was there. Was granny there, or was it just mum and dad looking a bit isolated? And it was so helpful. And I find that video gives me that window into an environment that again is super helpful, particularly for things like
Mm-hmm.
mental health. And also, where there's concerns about the sort of family dynamics and things, to hear people screaming at each other off camera, it gives you that window that can be really helpful to know, is there a safeguarding issue here? Do they need a bit more support? Are there other services that could be helpful? Because nowadays we do so few home visits that actually I feel we miss something that video can bring back.
Mm-hmm. And I guess one of the challenges, like you say, with visit is the travel time, because that's the thing that adds a huge amount of time in these consultations. And obviously the benefit video is it does basically get rid of the travel time. It does, however, have its challenges. Let's not forget that. So we talked definitely about some of the pros of video consultations. I guess from your perspective, what are the challenges and the negatives that we come across?
Just real quick, did you know that 87% of people watching this video are not subscribed? That's right, you're not a real EGP learner. So if you want to make sure you get all this amazing content as soon as it happens, subscribe, ring the bell, and let's get back to the content, shall we?
So I take you back to my dad's DIY advice as a tool for every job. If it's not the right tool for the job, then it's just not going to help you. So if the patient isn't happy, for example, to engage with the technology, if they've got a really clear idea, concern and expectation, and a really clear idea they need to see a doctor face to face, there's just no point faffing around, in my view. You might as well just see them the way that they want to be seen, or they will just keep coming back until you do, or bouncing into other services like 111 or urgent treatment centres. So I think that's the biggest one. I think the rashes we've talked about is a massive one. Things like chest pain, I think that's difficult, unless it is, to see if are they sweating and grey, or are they looking okay. So I guess, being really clear about the use of it. So are you using it for an additional triage of patients, or are you using it as the definitive consultation? And I think it can be used for virtually anything for an initial triage. But if that is your only form of consultation, I think you need to be an awful lot more careful. And there's things like, say, for the provision of palliative care, or chest pain, breast lumps, I think things like that, you need to be very, very careful with any sort of remote consultation, because some things really do benefit from a face-to-face and that human-to-human interaction, and our skill and all the skills we've learned doing clinical assessments that are much easier face-to-face.
Yep. I guess add into that, obviously, you've got the personal examinations. Obviously, they still can't be done by video, no matter how much some people may think it's possible. Trust me, they're not. You cannot do a PR virtually and things. And I guess the other one is also to think about the tech ability of the patients as well, and the support they may need. And let's be honest, just the infrastructure. Do they have a decent enough data stream that allows you to have a video consult? Because it does use more data than obviously, or tech than a telephone call and things.
But can I interrupt there, though? Yeah, because I think, though, people often make assumptions about people, maybe based on their command of the English language. But your patient who maybe doesn't speak English probably spends an awful lot of time video calling relatives elsewhere, and maybe a lot more comfortable than you think, and maybe have to patch in a family member to help with interpretation if you can't get a formal service by way of that three-way call. Or similarly with the elderly, I was quite amazed at how techie the elderly were on one small Orcadian island I worked on, until they said, well, of course we are. This is how we speak to our grandchildren every week. So I think it's so important not to assume, but to ask.
Yep, absolutely. And I've had numerous consultations with patients, over 70, which most people think, oh, they're not going to be able to do it and stuff. But actually, it's worked really well. And it's more importantly, it saved them having to come into the practice, like you say, just so that I can do that element of eyeball to deal with their health issues and stuff. And obviously then when it's needed for them to come in, we can make sure that that's done in the most appropriate way and the most appropriate time to help navigate their patient journey and stuff. I guess the other positive I found doing certain examinations that I think people find a bit unusual through a video route can be effective. My favorite one is for carpal tunnel, believe it or not. I think you can actually do most carpal tunnel examination checks with a patient over a video route, because actually majority of it's inspection, if you think about it. Very little of it is actual, palpation or other kind of things apart from tinnels. And actually, if you watch them do it, it's exactly the same as us doing it in some ways, and it's checking for the sensation changes and stuff. So the carpal tunnel kind of a test, I think, can be quite effective, as well as also joint mobility. So I know a lot of physiotherapists are using video as a way of assessing the range of movement that patients may have and stuff. And yes, there are obviously going to be some tests you can't do because you need to get your hands on and feel the things that happen, like feeling for the swelling is harder, but you can see it. And you can see how much range of movement they have as a result of it, and get them to even do certain movements. So obviously Job's test and all that kind of stuff, getting them to move their arms around and things can absolutely work, I think. So not to discount the examination prospects, aside from the obvious eyeball inspection that we mentioned, like for respiratory rate, sweating, all those kind of things and stuff. So I guess as we think about this more, what would be your key tips to people if they are thinking about using video consultations a little bit more effectively in general practice?
Yeah, it's all about thinking what you're trying to achieve from this video consult. Have a really clear idea going into it, what you're trying to get out of it. So, and that will help you to take the history. I mean, we do that anyway, don't we? Our focus history is based on what the patient's coming in with, but also in terms of the assessment, the examination as well. And I'd also suggest developing a pattern, thinking through how am I going to, say, assess a child's breathing on a video consultation, and practice it. See how people respond to the way you ask the questions. Do they do the things you expect them to, or are they kind of waving arms around or doing weird and wonderful things? And then tweak it. So PDSA cycle, plan, do, study, act, tweak it each time depending on the results you get, until you find a way of communicating with the patient that works in them doing what you need them to do and reporting back on it, or allowing you to see it. I think another tip I would have is being really careful about lag. We often speak over people by mistake because of those mini lags in the video consult, and trying to adapt body language to that. So saying less and nodding more, perhaps, sort of smiling, doing those things that you probably do on the phone to your mum. I think they're very helpful. Being aware of who is in the background as well. Some people like to ask a patient to sort of sweep the camera around the room so they know exactly who they're talking to. I don't do that, but maybe in a domestic abuse situation that would be helpful. And I think as well, if you're not getting all the information you need from the video consult, don't be afraid to say, I can't see what I need to here. I'm going to need to see you face to face. And I think that's really hard in hours, because in hours, if they've had 10 minutes of your time, it doesn't matter if it's 10 minutes of face to face or 10 minutes of video, they've still had 10 minutes. And it can be really tempting to sort of think, well, I've probably got most of what I need. But at the end of the day, if your spidey sense is tingling, or if you just feel you haven't got enough information, they just need to be seen face to face. And that is not a failure of a video consultation. That is giving useful information that you're using to decide on their ongoing care. And I'd say listen to yourself, and don't ignore any signals that you're feeling that this isn't quite enough. That wasn't quite the question you asked me. I can't remember what you asked me, but they're my top tips anyway.
No, so it was your top tips and stuff.
Okay.
So absolutely, I'd agree with that. I guess for me, one key tip I'd chuck in today is just make sure that you're comfortable doing video consultations and stuff. There's always this question about the empathy link that comes up, and that whole concept of where do you look, I guess, is another one to think about. And I guess this is one of the things I talk about with trainees as well, as they plan and start to do their SCA exam, which is obviously the new video consultation assessment. There's definitely something about looking at the camera and not looking at the screen that has an element of empathy kind of link that you have with the person that you're speaking with. Because when you obviously look at the camera, it's like you're looking directly at the person, and therefore they feel that element when they're doing the consultations. Obviously, the challenge is with general practice, you can't do that all the time, and it takes a skill to do it. I've got the years of experience of doing videos and stuff like that, so kind of got used to it and things. But What I tend to tell a lot of people is when you are looking at the screen, just tell the patient you're looking at the screen. So then that they're aware of that fact, and that can help with that kind of slight disconnect. Otherwise, it kind of looks like you're just looking up in the background. And I guess if you bring that back to real world, when you've got a patient in the room, would you want to look at the screen all the time and not the patient? Yeah, it's not going to work.
Yeah, and I think that's a flip side as well. Like, sort of, some people feel really stared at on a video consultation. So just like in normal conversation, we'd look at somebody, look away. Don't, try and look at the right bit of screen. I fail this every time, particularly today, because I'm talking to you from an iPad, so the camera isn't quite where I expect it to be. But equally, I wouldn't stare solid at you for 20 minutes in real life. So I think, sometimes we can get so hung up on this that it makes it awkward too. So I think it's great advice. Some people put a little sticky, right at the top of the screen near where the camera is to remind them. And other people find it really helpful to put a post-it note over the image of themselves, because some people find it really, really distracting to have themselves on the screen, and just sticking a post-it note over it is all that's needed for them to focus more on the patient and that rapport to grow.
Absolutely. And I guess other things just to be aware of the tech itself, to make sure you've got enough download and especially upload speed. That's probably the big one in terms of how you look to other people. You need a decent upload speed, and being aware of the high and low points that may happen in practice. I know that's something we have. So when loads of people are on, it goes down, and then as a result of that, it doesn't work as well. So times it may be more opportune and stuff and things to have a look at. So thank you for that, Rebecca. We've covered loads of stuff around consultations and that kind of thing. I guess if people did want to check out more information, feel free to check out some of the other content that I've got. I'll put some links, I know, to stuff that Rebecca's got as well to help people do video consultations more effectively, as well as that paper that you mentioned that you're looking at and stuff. I guess as we head towards finishing off, where do you see the future of video consultations heading within primary care and general practice?
I think that's such a challenging question, because the question is, where is primary care heading, full stop? And if we're going to be doing primary care at scale and sort of move away from a more corner shop type model of general practice, I suspect there will be more of it, because if you haven't got a GP locally, it does give you more than just a phone call. If we're going to be able to maintain that really personalised general practice that has really been the bedrock of the NHS care, our sort of, I'll get evangelical now, John Stott Davis's model of, all the stuff we do, that opportunistic health promotion, chronic disease management, addressing the presenting complaint, and what's the other one? There's another one. Addressing their sort of help-seeking behaviour. I think traditional general practice gives a real bang for the buck, because it can do all of those. And so rather than have 4 different consults for those 4 different things, we do everything. And I think that sort of model general practice really lends itself to relationships, personalisation, face-to-face encounters. But I do worry that is not the direction of travel. And if we're going in a very different direction, I think video consulting will have a large role to play. I think it also has a large role to play in the out of hours period, where it's just so helpful, particularly when you're going to need to justify patients travelling long distances or waiting several hours. So tool for every job, and thinking about the job and thinking, is it the right tool? That's my sort of thoughts about where it fits.
Absolutely, definitely agree with that. I'd probably chuck in there that whole potential of secondary care, joint consultations maybe and stuff. I think there's something really potentially quite valuable that could be achieved with a bit more effort into that particular area, but who knows, we shall see. Obviously, if you do want to check out more resources that we've got on EGP Learning, do feel free to check out this video right here that tells you about some of the tech stuff you need to be aware of when it comes to video consultations, specifically around the FCA exam, but it applies to any type of video consultations, including my own key hints and tips, and one that you're absolutely going to love. And if you want more information, check out these ones coming up here for other kind of content as well, as we continue to tech enhance your primary care and learning. And we will catch you in the next episode.